welcome back to XGate Dental. I'm Emmanuelle, and we are here to discuss new procedures in the field of dentistry. We will provide interesting new cases to exhibit how doctors use our products to solve complicated dental cases, so don't forget to subscribe and follow us to stay up to date. Let's get started. Today we're going to talk about a case where we have a full jaw restoration. We have a cross-arch bridge on the lower jaw, and at first we made a bridge from PMMA. Then we switched to Zirconia, and we want to show the whole process when we choose what types of multi-units and what types of sleeves and how we take impressions. And in this case, we even redid the job because we saw there isn't enough material to hold the forces that applied on this bridge. Here you can see how the lower jaw with the implants and the multi-units. This is at the moment when we make the PMMA bridge on those multi-units. We're going to mount the bridge on the multi-units and we're going to check how the bridge fits. In these cases, when we have lower jaw cross-arch bridge, we always have a provisional bridge because we want to see if the anatomy and the structure of the bridge is suitable for the patient, if it's comfortable and if the patient has good function with the bridge. When we have implants with different angulations, it's sometimes even better because the bridge will hold in different angulations, in different directions of applied force. The whole bridge will be, as a structure, much stronger. Within the small angulation, it's great. It's even probably preferable to have some slight deviation from the straight parallel multi-unit implants. This is the PMMA bridge. We made the bridge for this patient. The patient doesn't want to change his upper teeth, only the lower ones. So we've made a PMMA bridge so he could walk with this bridge and feel it's comfortable enough, and if the bridge suits his requirements. And then later on, if we see that everything is good with this bridge, we'll make a new one from Zirconia or from any other material that you want. One of the options in the libraries for those multi-units is that you can have a very small screw channel. When you have a very small screw channel, you have more material around the sleeves and around the multi-unit. So the structure as a whole is much stronger. And this way, even though you don't have enough, or it seems like you don't have enough material, when you make the screw channel a little bit slower, it adds to the material and the structure as a whole is much stronger. With angulated ones, it's a problem because you need to have a very high bridge, and we don't have this option. But for the V-type multi-units that we have, it's not a problem because all the structures are much smaller and you have place to make small screw channels and to place the screw within the bridge. So even if you flip the bridge, the screw won't fall. So it's much easier in the mouth attached to the screw. This is inside the mouth. You can see because the patient doesn't want to change his upper teeth, even though he has some problems in there, we didn't want to make the teeth in the occlusion. So the frontal teeth are much higher and the lower ones are much smaller. Not the most aesthetic result, but it's functional. And if the patient doesn't want to change the frontal part, you don't have any other option. You can't leave open bite in the interior part. You see the contact and you do have occlusion. You don't want to have two strong contacts in the frontal area because you only have one implant there. To the side of the posterior area where you have the molars, the premolars where you chew the food, and this is the problem in this case. What we saw is that the bridge broke. Those implants are very old, so you can see in some places that part of the implant is outside of the bone. You had a bone respiration and you have gingival recession, and the multi-units that were used are the smallest multi-units available. So you can't make a thicker bridge by lowering the height of the multi-unit. We don't choose a multi-unit a few millimeters above the gingival line. So in this case, you don't have any other option because the implant is in the bone. You don't want to extract the implant. The implant is osseointegrated. There is some bone resorption and the patient needs to have teeth, and we use the smallest multi-unit. So in this case, to have more Zirconia, to have more PMMA to make a stronger bridge is the best option. Because in the frontal area you have a thick layer of PMMA, it holds all the forces. In the right side of the patient, there's a thin layer of PMMA, and all the chewing forces and a lot of chewing forces are in the functional forces are applied on this area. So the bridge broke in the lowest, in the easiest place it can break. So we thought that we can make a Zirconia bridge the same as the PMMA bridge. We made the Zirconia a little bit thicker in the buccal lingual aspect, and we thought it would hold. We have a great Zirconia bridge that looks amazing, even though we made small screw channels and even though we made the bridge much thicker in the buccal lingual aspect. Still, the bridge broke. When you don't have teeth and you have implants and most of the people chew much large forces, when you have a broken bridge, you need to make a new bridge. It's maybe the case that you have bruxism. So for bruxism, zirconia is one of the best materials because you don't wear your teeth in a higher rate, as with PFM, for example. But still, you need to make an even thicker layer of zirconia. So first of all, we took a new impression because one of the things that we thought that can be a problem is the lack of passive fit. If you have a full zirconia bridge without passive fit, it is possible that there are some internal forces that are applied on the bridge. So we decided to take another impression. This time we didn't take an impression with the intraoral scanner, and we took with the analogs way, with the transfers and everything. We connected all the transfers with all the caps and we took an impression. The lower jaw is very problematic in taking digital impressions because of all the movements. You have the tongue, you have the cheek, you have the movable gingiva. It's very hard to take a good intraoral impression for the whole jaw on the lower jaw. There are methods to make this impression much more accurate and much better, but it's still a problem. So in this case, we already had one failure. We didn't want to make another one. We wanted to make the best possible bridge that we can, and we chose to take the impressions in the analog way. The colors of the transfer cap goes with the color of the transfers. So you have different transfers for different gingival height. Before we said that those implants on the right side of the patient are with bone resorption and are problematic. So we use the smallest transfer, and the smallest transfer comes with a white cap. It's in a white color, a metallic color. The frontal transfers that goes on the implants that we implanted not long before we started this case have much thicker gingival. Now, without bone absorption, they're not problematic. Those implants are very old. When you have a system of different transfers, then you give the impression to the technician, and the technician needs to put the transfers back in the impression. So you can write on the paper what transfer you did use, but most of the time it's problematic because first of all, you can make a mistake. You can write something backwards, or maybe what you wrote got lost in translation between the doctor and the technician. So in this way, the technician knows exactly what transfer that you used because you used caps in the same color. We made a putty wash impression. You can see that at first we took impressions with only the putty, and then we added some wash and made a pickup with all the caps connected to all together with the composite material. This is the new zirconia bridge. You can see that all the sleeves are the same height except for one. One of the sleeves we took and we just made the small sleeve and we closed the screw channel as a whole. So you have the thickest zirconia possible for this place, for this area, and it worked. This is the most problematic part. This is where it broke. This is how we fixed it and it worked. This was a couple years ago and it still works fine. We left all the bridge the same and then changed the stopper and closed the entire screw channel, and this gave us a lot of zirconia material. Just because we had a problem in one area doesn't mean that the second part needs to break. It's not that we took off the inclusion in this part and now all the forces go to the left side. The bridge is the same. You have occlusion on both sides, and the side that's down now is much stronger. So the left side is the same, didn't break, and the right side is much stronger. So now when he's chewing on the right side and on the left side, everything else is the same and not a problem. We used toothpaste to cement the sleeves to hold them while we cemented them inside the patient's mouth, so that this way we can ensure that we have a passive fit. Now, you use the small spacer that you have between the zirconia and the sleeve to passive fit the bridge to make the connection between the bridge and the multi-units and the implants, which are much more passive. So you won't have internal forces, and the bridge as a whole will be much stronger. So we start by screwing the first three, the first frontal, and then go back step by step, washing the toothpaste. Theoretically, you can cement them at once, but the problem is that the cement for the sleeves, it hardens with time. So you don't have enough time to cement and glue everything and then put all these sleeves in the bridge and put it in the mouth and screw everything in. It will just harden itself within a couple of minutes, and you need to do this very, very quick. So in this way, we have enough time to cement all the bridge and just by segments. Now we're going to screw the back 5. Then we take out the bridge because we need to clean the residue of the cement, and you can see that we have some residue that we will clean. This is the compensation because the sleeve can move a little bit inside the zirconia. Now you can, with the composite material, with every material, close these gaps, and you won't have any internal forces between the connection to the zirconia bridge and the sleeve. Using this method, it means to be perfect, but ultimately you can't make everything perfect because you take impressions, you have some inaccuracies in the system because maybe you didn't screw the transfer as you should. Maybe something got in the way. Or maybe the technician didn't put the transfer. Maybe you had some problems when you made a gypsum model, the analog moved a little bit. Maybe when you milled, you had some deviation. Maybe when you sinter the zirconia, you had some deviation because you take the material that is fragile like chalk and then you put it and you sinter it off and get something like a rock. So in the process of the sintering, you can have some inaccuracies, and all of those inaccuracies will want to compensate. We don't know where it happened, and we don't know that it will affect the end result. So to overcome those inaccuracies, what we do is we use the spacer between the bridge, between the zirconia and the sleeves to compensate on those inaccuracies. You can see here the whole sleeve and all the sleeves cemented to the bridge. We have the same bridge with glaze, and right now in here we have much more material. We have much more zirconia. The bridge as a whole is much stronger, and the patient wanted white teeth because when he'll choose to change his upper teeth, he'll want them also white. Anyway, thank you everyone that joined in to learn some new and interesting information. Make sure to tune in for more, and of course, don't forget to subscribe, like, and follow. Thank you, and see you guys next time.